All right, welcome to the deep dive. Today we're tackling a condition that's really crucial to understand, postpartum psychosis. Maybe you're deep in revision mode, or maybe you just want to be really well informed about maternal mental health. Either way, you're in the right place because this deep dive, it's built specifically from your revision notes on this topic. Our mission is basically to take this stack of material and, forge it into a clear, high-yield guide, hitting all the essential points without getting lost.
And this is a deep dive that truly matters, doesn't it? Postpartum psychosis, often called PPP, it's rare, yeah, but it is incredibly serious. We're talking a genuine psychiatric emergency. It's got potentially devastating implications, so prompt recognition, prompt intervention. It's vital. Getting a solid handle on it is just, essential.
Okay, yeah. Let's unpack this then. Let's jump right in with the fundamentals. What is postpartum psychosis at its core?
Okay, so the core definition from the notes.
Yeah.
It's basically a rare but very severe psychiatric condition.
Right.
Presenting after childbirth.
Severe.
Yeah, and the key features are that sudden onset of psychotic symptoms, things like delusions, hallucinations,
Right.
really disorganized thinking. And that's combined with very severe mood disturbances. We typically see this pop up within the first few weeks after delivery.
And the material really stresses this is a psychiatric emergency.
Absolutely. Needs immediate medical attention, no question. And it's so important to understand this is distinct from postpartum depression.
Okay.
PPD is more common, sure, but PPP is like way more severe. Hospitalization is often needed for safety, for evaluation, for treatment. It's a whole different ballgame in terms of severity.
Got it. Distinct severe needs urgent help. Okay. So that leads us to the why. Why does this happen? What are the potential causes behind PPP, according to the notes?
Well, the exact cause isn't fully pinned down.
Mhm.
The information suggests it's likely a complex interplay of factors.
Not just one thing yet.
No, definitely not. A big one seems to be those dramatic hormonal fluctuations after childbirth, especially that rapid drop in estrogen and progesterone. There's also likely a genetic component involved. We see that mentioned. And then you've got the psychosocial factors, things like severe sleep deprivation.
Which is almost universal with a newborn.
Exactly. But here, it seems to tip the balance. Also, high stress levels, maybe feeling social isolated, or just really struggling to adapt to the huge life change of motherhood.
Okay, so hormones, genetics, psychosocial stress. And I notice a significant link mentioned to bipolar disorder.
Yes, that's a really important connection highlighted in the material. For some women, postpartum psychosis might actually be the first time an underlying bipolar disorder shows itself. Or it could be an episode triggered by the postpartum period.
Oh, okay.
So when thinking about the why, it's multifactorial. Maybe think hormones, genetics, psychosocial factors, and maybe sitting on the spectrum of bipolar disorder. Sort of helps tie it together.
That does help link those ideas. Okay, so knowing the potential causes, who is most vulnerable? Understanding the risk factors feels absolutely crucial for spotting this early.
It really is. And the information gives us a pretty clear list. The ones that really jump out with the highest association are a personal or family history of bipolar disorder, or, importantly, a previous episode of PPP itself.
So if someone's had it before, or a close relative has bipolar or PPC.
Their risk is significantly higher. That's a major one. Other factors include a history of any psychotic episodes or other significant mental health disorders.
Yeah.
And, this is important too, if someone has recently stopped taking mood-stabilizing medications.
Ah, okay. Like coming off lithium or something similar.
Potentially, yeah. Then there are pregnancy-related factors. Being a first-time mother, primiparity, or having pregnancies very close together. Lack of social support is a big one. Severe sleep disturbance, as we mentioned. And stressful life events, either during the pregnancy or right after childbirth.
Makes sense.
And finally, a couple more. A history of mood symptoms getting worse before periods, that premenstrual exacerbation, and just a general family history of psychiatric conditions.
So it sounds like underlying vulnerability, especially around mood and psychosis, then combined with the physiological shock of childbirth and maybe lack of support, that creates a higher risk scenario.
Exactly. That prior personal or family history is definitely a major red flag to be aware of.
Let's dig a little deeper into the biological side, the pathophysiology. How do we think these risk factors and triggers actually translate into the symptoms we see? What's the mechanism as far as we know?
Well, our understanding, based on the material, points back to those hormonal changes again, especially that rapid drop in estrogen and progesterone, somehow contributing to the psychotic symptoms.
Right.
Genetic factors clearly play a role in susceptibility, and there seem to be alterations in specific neurotransmitter systems in the brain. Dopamine and serotonin are mentioned specifically.
The usual suspects in mood and psychosis research.
Pretty much. They're often implicated. So ultimately, it's viewed as this complex interaction between these rapid biological shifts and someone's genetic predispositions.
Okay, this leads us to a really critical clinical step: differential diagnosis. If someone presents with these worrying symptoms after delivery, what else could it possibly be? What are the important lookalikes we need to rule out?
All right, this is non-negotiable detective work. The notes divide the possibilities nicely into two camps: psychiatric and, crucially, organic causes.
Okay, let's start with the psychiatric one.
Sure. On the psychiatric side, you need to think about severe postpartum depression, maybe with extreme anxiety, a new onset or flare-up of bipolar disorder, major depressive disorder that includes psychotic features, that's a specific subtype, or potentially schizophrenia, maybe a first episode, or other primary psychotic disorders.
Okay, a range of serious psychiatric conditions.
Yes, but here's where it gets really interesting,
Yeah.
and maybe even more critical in the immediate term: the absolute necessity of ruling out organic or medical causes.
Right. Physical illnesses mimicking psychiatric goals.
Exactly. And the list mentioned is quite extensive. Serious things like stroke ischemic or hemorrhagic,
Right.
electrolyte imbalances, sodium levels going haywire, causing confusion,
Right.
blood sugar problems, or hyperglycemia, thyroid or parathyroid abnormalities.
Which can definitely cause mood and cognitive changes.
For sure. Severe nutritional deficiencies like B12 or folate, side effects from medications they might be on, and infections. Sepsis is a big one, or even a urinary tract infection presenting atypically in this vulnerable state.
Okay, I have to ask here, why is considering these medical causes so incredibly vital? Why is that the absolute first step, even before you land on a psychiatric diagnosis?
Because many of those organic conditions are immediate medical emergencies themselves.
Right.
A stroke, severe sepsis, a major electrolyte imbalance,
Mm.
these need rapid medical treatment that's completely different from psychiatric management. If you delay treating those because you're only thinking psychiatrically, the outcome could be, well, fatal. You must rule out a treatable, potentially life-threatening medical cause first. It's just fundamental patient safety.
That makes perfect sense. Protects against missing something urgent while figuring out the psychiatric picture. And the material gives us a helpful way to think about the key medical tests, right? That BU, TCH, mnemonic, plus a couple extras.
Exactly. It's a good way to remember the core investigations you'd typically run to rule out those organic causes. So BUTCH plus urine and maybe a head scan.
Let's break that down.
Okay, B is for basic bloods like a full blood count, FBC, looking for infection or anemia. U is for urea and electrolytes, UNEs, checking kidney function, those crucial electrolytes. T is for thyroid function tests. C is for calcium levels. Hypercalcemia can cause confusion. H is for haematinics B12, folate checking for those deficiencies.
Okay, that's BUTCH. Then urine.
Yeah, urinalysis or a midstream urine sample, MSU, to check for a UTI. A urinary drug screen might also be relevant sometimes.
And head scan.
Cranial imaging, like a CT or MRI. That's if there's any suspicion of a neurological cause, like a stroke, bleed, infection, or some other structural issue in the brain. It's essential to exclude those if the clinical picture suggests it.
Brilliant. So that mnemonic helps guide the investigation part, focusing on excluding those dangerous mimics. Let's put this in perspective now with some numbers. What does the epidemiology section tell us? How common is PPP and who does it affect statistically?
Right. So in the UK, the incidence figures cited are relatively low, about 1 to 2 cases per 1,000 deliveries.
So not common, but clearly significant when it happens.
Precisely. And as we touched on, the typical onset is quite early, usually within the first 2 weeks postpartum, sometimes even sooner. The stats also reinforce those risk factors we discussed. There's a significantly higher risk. The notes mention up to a 6-fold increased risk if there's a family history of PPP or bipolar disorder.
Wow, 6-fold.
Yeah. And having had a prior psychiatric hospitalization related to pregnancy also bumps up the risk considerably. And here's a really sobering statistic the material highlights. PPP is cited as a leading cause of late maternal death in the UK.
That really hits home, doesn't it? Underscores why this deep dive, why awareness is so important.
Absolutely. It emphasizes the need for vigilance and early intervention, both during pregnancy and especially in that vulnerable postnatal period.
Okay, moving from the numbers to the presentation itself, what does PPP actually look like? If you were interacting with someone affected, what clinical features would you typically see? This feels like the core of recognition.
It usually presents quite suddenly, and it's severe. The symptoms can vary, of course, but often it's a mix of psychotic elements and extreme mood disruption.
So let's break down those symptoms. Psychotic first.
Okay. You might see delusions. These are often focused on the baby, maybe fears about harming the baby or that the baby isn't theirs, or sometimes grandiose ideas related to motherhood. Hallucinations are common, typically auditory hearing voices, but other senses can be involved. Then there's disorganized thinking or speech. The person might seem very confused, jump from topic to topic, or be quite incoherent. Paranoia is also listed, feeling overly suspicious, perhaps fearful of others harming them or the baby, and holding odd or frankly bizarre beliefs, often related to the baby.
Okay, that's the psychotic side. What about the mood and energy changes?
These are profound too. You can see extreme mood swings, maybe rapidly cycling between feeling very high, elated, irritable, wired, manic-like, and then crashing into severe depression or despair. There's often severe agitation or restlessness. They just can't settle. And sleep is hugely disturbed. Often profound insomnia, sometimes even a decreased need for sleep, coupled with bursts of hyperactivity or excessive energy. Irritability and anxiety are also very common.
That sounds incredibly distressing and, well, chaotic for the person experiencing it and for those around them.
Absolutely. And other signs can include things like decreased appetite, neglecting basic self-care, and general confusion or disorientation about time or place.
And the material explicitly flags a crucial safety concern here, doesn't it?
Yes, and this is paramount. It cannot be stressed enough. The presence of thoughts of harming oneself or, tragically, thoughts of harming the baby. The distorted thinking, the delusions, the paranoia caused by the psychosis can lead to these impulses. This risk is precisely why the condition is an immediate medical emergency. Safety first.
Right. Any hint of those thoughts means urgent, immediate intervention. The material notes the severity and duration can vary, but crucially, any of these symptoms warrant urgent attention, right? Not just the full-blown picture.
Precisely. You don't wait for it to look textbook perfect. If there are concerns, especially around psychosis or severe mood shifts or safety, act quickly.
Okay, so you suspect PPP based on these features. You've done your BUTCH investigations to rule out organic mimics. What's next? Section 9 covers management. How do you actually treat PPP? What do you do?
Management has to be immediate and comprehensive. The notes emphasize this. The very first step is almost always hospitalization for immediate stabilization, for safety, and for close monitoring of both the mother and the baby.
Okay, inpatient care.
Yes. Inpatient psychiatric care is essential. You need a safe environment to manage these severe symptoms. Urgent assessment, referral, and admission are key. Ideally, the notes mention, to a specialist mother and baby unit if one is available. This is the UK context described.
That allows keeping mom and baby together safely.
That's the goal, yes. Maintaining that bond while ensuring safety. Medication is a core part of treatment. Antipsychotic medications are typically used first line to address the psychotic symptoms. Mood stabilizers like lithium or valproate are also crucial, especially given that link to bipolar disorder. They help stabilize the severe mood swings. Antidepressants might be considered sometimes, but usually carefully, perhaps after the acute psychosis and mania are controlled.
What about other treatments?
Electroconvulsive therapy, or ECT, is mentioned as an effective option. It's considered for very severe cases, or perhaps if medications aren't working well or are contraindicated, maybe due to breastfeeding choices. ECT can provide quite rapid relief.
Okay, so meds and potentially ECT for the acute phase. What else?
Beyond that, psychosocial support and psychoeducation are vital, helping the woman and her family understand the condition, how to cope. Therapy, individual or group, is seen as supportive during recovery. But the material specifies it doesn't really have a role in the acute phase itself. That's about stabilization.
Right.
Supportive interventions are also key. Things like practical help with childcare, getting the family involved and educated, and really working on maintaining and strengthening that mother-infant bond, avoiding separation whenever it's safely possible.
That seems really important for the long term.
Definitely. Post-discharge planning is also crucial, setting up follow-up appointments, ensuring ongoing monitoring and support systems are in place, and decisions about medication, especially if the mother wants to breastfeed, need careful weighing of the risks and benefits for both mother and baby. It's an individualized discussion. Education and support for the whole family unit is a thread running through the management plan.
It really sounds like a coordinated, multidisciplinary effort focused squarely on the safety and well-being of both mother and baby.
Exactly. It's intensive upfront intervention, followed by robust ongoing support tailored to the individual.
So after going through that intensive treatment, what does the future typically hold? Let's look at the prognosis section. Is full recovery common?
The good news, generally speaking, is that with timely and appropriate treatment, the prognosis for PPP is quite good.
That's encouraging.
It is. Most women do experience significant symptom improvement and can achieve a full recovery over time. However, and this is a really critical point for future planning and counseling, there is a significant increased risk of recurrence.
Ah, in future pregnancies.
Yes, especially in future pregnancies, but also potentially during other periods of major hormonal fluctuation. This means close monitoring is absolutely essential in any subsequent pregnancies. Preventive measures are often discussed and recommended. This might involve restarting medication prophylactically during or after the next pregnancy and ensuring really strong psychosocial support systems are in place beforehand. The material highlights that the recurrence risk is relatively high, so that needs to be managed proactively. The overall prognosis can also be influenced by things like how severe the initial episode was, if there are other coexisting conditions, the quality of social support available, and of course how well treatment is adhered to.
So recovery is the norm with treatment, which is great news, but vigilance and planning are absolutely key for the future, especially around subsequent pregnancies.
That sums it up well.
Finally, let's look at the flip side, complications. What happens if PPP is not treated effectively or promptly? What are the risks?
If left untreated, the consequences are, frankly, severe and potentially tragic for both the mother and the infant.
For the mother.
The risks include self-harm, suicide attempts or completion, and as we mentioned earlier, that awful risk of harming the baby, driven by the distorted psychotic thinking. Untreated, it inevitably leads to prolonged hospitalization, often necessary separation from the baby, and can have a significant long-term negative impact on the mother's mental health, her relationships, and her overall functioning.
And for the infant, that must be devastating too.
Terribly so. There can be impaired bonding between mother and infant, which has long-term implications. Significant difficulties with caregiving because the mother is so unwell. This increases the risk of child neglect, even if unintentional. And infants can experience emotional and developmental difficulties down the line as a consequence of that disrupted early caregiving environment and exposure to maternal distress.
Those are really devastating potential outcomes. It truly underscores why prompt identification, intervention, getting that help immediately. It's not just important, it's potentially life-saving for both.
Absolutely. Immediate action and comprehensive ongoing support are crucial to minimizing these terrible complications and helping the whole family unit recover and thrive.
Wow, okay. We've really covered a lot of critical ground there, following the path laid out in your notes. We went from defining postpartum psychosis, stressing its emergency nature, exploring the potential causes, the why, and who's most at risk. We looked at the biology, the pathophysiology, navigated that crucial step of differential diagnosis, ruling out those organic mimics with things like the BUTCH checks. We touched on the epidemiology, the numbers, described what PPP actually looks and feels like, those clinical features. Then outline the investigation process, the comprehensive management strategies, including hospitalization and meds, and finally considered the prognosis generally good with treatment, but also the high recurrence risk and the serious complications if left untreated. I think the core takeaway here is pretty clear. PPP is rare, yes, but it's a genuine psychiatric emergency needing urgent help. While it's incredibly challenging, with the right, timely treatment, recovery is generally the expected outcome. But being aware of that significant recurrence risk, especially in future pregnancies, is absolutely essential for ongoing care and planning.
Yeah, and maybe a final thought to leave people with. Thinking about how those really rapid, profound biological shifts after birth, how they can intersect with underlying vulnerabilities to trigger such a severe mental health crisis. It just powerfully highlights that deep connection between our physical state, our hormones, and our psychological well-being. And maybe more practically, it really emphasizes how vital it is for families, partners, friends, and all healthcare providers to be vigilant, to recognize the signs in a new mother, and know when to seek urgent help, not just dismiss significant changes as baby blues or normal tiredness. Early action makes all the difference.
Well, that's a really powerful and important thought to end on. Thank you for joining us for this deep dive unpacking your notes on postpartum psychosis. For those of you using this for revision, maybe for the MSRA or other exams, or just wanting to expand your understanding, we really hope this has been a high-yield session for you. Remember, this deep dive was built using the resources mentioned in your notes. You can find more resources and specific revision materials, especially if you're preparing for exams like the MSRA, over at passthemsoyouPray.com. And also, definitely check out the free resources available at freesra.com. Lots of good stuff there, too. Thanks for listening. Until next time.